Hello, everybody. It's a pleasure to be here today with you to have the chance to present you several studies that were presented at ESMO conference in Madrid in October 2023. My name is Zorana Maravic, and I'm the CEO of Digestive Cancers Europe, which is the European umbrella organization supporting patients with digestive cancers. And I have a pleasure that today with me at this session is Professor Dirk Arnold from Hamburg, Germany. Dirk, could you please present yourself and then present the selected studies?
Zorana, thank you for the kind introduction. And dear friends, patients, whoever is interested, it's a real pleasure to introduce, let's say, some of the novel findings in locally advanced colon cancer, since this is so important to, let's say, give better treatment here in this field where this has been so under-researched over the last year, specifically this field of locally advanced colon cancer. But I will come to this in a minute after having shown the disclosures, and I can assure you that there's no conflict of interest in my presentation here. So as I was mentioning, in this session, we talk about localized colon cancer, stage 2 and stage 3. We'll say with or without lymph node, with a clear goal to surgically remove the tumor and to aim cure. However, as we do know, some patients relapse, too many relapse. And the question is, what can we do in addition to surgery? The standard is clear to add adjuvant chemotherapy. And here the key question is only for whom and how intensive should this be? And, or that's the new development, apply perioperative treatment. And to start with perioperative treatment, please wait a second for this, because first of all, before we do the perioperative treatment, we have to revisit what we have been doing so far. And there has been an analysis which is very important for us as medical oncologists and those which treat these patients to know better about the prognosis of patients when we think about perioperative treatment. Because when we do today a risk assessment, we rely on counting of lymph nodes, we rely on clinical staging, which comes from the pathologist. But so far, we do not have a big database for the molecular makeup of patients and the prognostic implications. Julien Taillep, as coordinator from all European study groups, was, let's say, composing a research consisting of 7 randomized trials for adjuvant treatment from different groups all across Europe. And they were analyzing more than 8,000 patients with a full molecular imaging of this patient with regard to MSI status, BRAF status, and RAS mutations. As you do know, these markers are important for metastatic disease since they predict specific treatments. However, they may also predict treatment in the locally advanced colon cancer and may also have a prognostic implication. However, we are not really aware what this means. Today, we do know that in some patients, MSI, BRAF, and RAS do exist, and that they also have a prognostic information. And the result of these 8,000 patients been showing here is that, for example, we have learned that about 10% of patients, 11%, have an MSI high tumor, whereas 88%, 89% have an MSS or proficient mismatch repair system tumor. We also know that further mutations next to this MSI status occur at different levels. For example, we do know that for the MSS now, more patients have no further mutations, whereas in the MSI group of patients, more patients have also, next to the MSI status, a secondary mutation, mostly BRAF more than RAS mutations. And we also do know that we have a different profile of RAS mutations when we sub-analyze them by MSI status. So that's really important because we will have newer developments in the very near future, also in metastatic disease, for specific RAS mutations, and we come to this later. However, what have we also learned? We have learned that prognosis of patients has to do with the MSS or MSI status, first of all, and also then with coexisting other mutations. But as you can already numerically see here, and I will show this to you in a second, the majority of patients with MSS tumors had then a different prognosis when they had secondary mutations, whereas the MSI patients had a better prognosis and no difference when other mutations were also existing. And to graphically show this, these are these survival curves. So if we have an MSS status, we do know with no further mutations, patients have a way better prognosis than if they also have, in addition to the MSS status, a BRAF mutation. However, if they are MSI high, there is obviously not a difference in their prognostic implication. So therefore, what have we learned from this? This is the largest analysis of the association of these different mutations and the prognostic implications. And we do know this to better define the need for adjuvant treatment after surgery. However, that's not the final end of this story. In the very near future, we will also have this molecular makeup and the molecular characterization, not only in the tumor, we will also have this in the blood of patients in the plasma versus liquid biopsy or the analysis of cell-free tumor DNA. But now we do have this atlas, we have this background, and we can then clearly interpret the data from the liquid biopsy with respect to the frequency and the prognosis of the tumor. And this will further help us to determine treatment intensity. However, this has been adjuvant post-operative treatment. And I've already in my introduction mentioned that we may switch somehow to preoperative treatment. When is preoperative treatment relevant? Well, preoperative treatment is then relevant if we do see that we have advanced localized tumors. These are a few examples. You can see that this large tumor is infiltrating the chest wall. And here we can see that this tumor is infiltrating the bladder. Of course, the surgeon can remove these tumors. However, it's unclear whether he or she can remove this completely with an R0 resection and or whether we could have a less invasive surgery if we shrink this tumor before the surgeon starts to remove these tumors. This following the Foxtrot trial has been, let's say, created. Foxtrot trial is a large trial being driven by the British group looking on preoperative chemotherapy for patients with locally advanced colon cancer. And what they presented here at the ESMO meeting is one out of these arms of this Foxtrot trial with this neoadjuvant intensified treatment with FOLFOX and panitumumab. So as I was mentioning before, the Foxtrot trial, which has been published this summer, has shown the benefits of a neoadjuvant chemotherapy in this locally advanced colon cancer. And we now look on this embedded phase 2 trial with the addition of the anti-EGF receptor antibody panitumumab in patients with RAS wild type. And as I've just shown you some slides ago, nearly 40% of all patients have a RAS wild type status in localized colon cancer. So therefore, the research of Julien Taïeb and this group is so important. So what was done here is a randomization of these 233 patients with operable colon cancer with RAS wild type status, locally advanced colon cancers, and they were randomized to preoperative FOLFOX versus preoperative FOLFOX and the anti-EGF receptor antibody. All patients were operated, and after operation, according to lymph node status, adjuvant treatment was completed. What were the outcomes? If you look to the relapse-free survival, to date only 169 patients are to analyze, you can see that the rate of patients without any relapse is about 9% higher in the group of patients which underwent treatment with FOLFOX and the anti-EGF receptor antibody. We can see that also some further biomarker analyses may help us in the future to even better sharpen the profile of these patients. But so far, for the moment being, when we do think about neoadjuvant or preoperative treatment, it seems to make sense to give the best treatment here according to the molecular pattern. So on the other hand, we have to say that panitumumab was associated with a higher rate of grade 3 diarrhea and skin toxicity, as we do know this and slightly more surgical complications compared to FOLFOX alone. So therefore, what can we say in summary? These neoadjuvant FOLFOX and panitumumab shows promising activity in these patient group, which are suitable for this treatment according to their molecular profile. This is better than adjuvant FOLFOX, but more and better biomarker analysis is necessary. And I would say this is not yet a standard in a currently rapidly evolving field. And having said this, I would love to come to the last aspect of this neoadjuvant treatment, which is really opening the door for a super tailored treatment. And this is neoadjuvant treatment for localized colon cancer for patients with mismatch repair deficiency. And again, as I showed you in the beginning of this presentation, about 12% of all patients with localized colon cancers have mismatch repair deficiency. And we do know that in the metastatic setting, here, chemotherapy is not as efficacious as immunotherapy. Well, we turn the clock back 1 year. 1 year ago at ESMO 22, we have learned that in the niche 2 trial, this non-randomized trial, more than 100 patients with locally advanced non-metastatic dMMR, so we'll say MSI high colon cancers, had a treatment with an immunotherapy combination. Miriam Shalabi at this time presented data from patients which underwent 6 weeks, only 6 weeks, only 2 treatments of this immunotherapy combination. And she reported in this readout of this impressive curve, which many of you have seen at many meetings. This shows that only after 6 weeks of treatment for locally advanced MSI high colon cancers, nearly 100%, nearly all patients had a major pathological response. We'll say when the tumor has been removed by the surgeons, there was no vital tumor anymore. And in 2 out of 3 patients, there was no vital tumor anymore. So 67% complete pathological response rate of the immunocombination she has been presenting last year. Now, the niche 3 trial is a smaller trial coming from the same group, but the same approach. 19 patients, locally advanced colon cancers, MSI high tumors, and the treatment combination here was nivolumab and another immunotherapy agent, relatlimab, which is an anti-LAG-3 antibody. Also, this treatment only consisted of 8 weeks of treatment, so not long, 8 weeks. And again, the endpoint was pathological response, and findings were not really different. In fact, it was even a bit better than with the other combination in this small patient cohort. 100%, we'll say all patients had any pathological response, and 4 out of 5 patients had no vital tumor anymore after they underwent only 8 weeks of this immunotherapy treatment, so only 2 administration of these immunocombinations. So what are the findings here? That's, again, the first trial to show this combination, the efficacy of this combination. You've seen this outrageously high efficacy in 4 out of 5 patients showing a pathological complete response. Of course, we do need further data. And I would say for the clinical meeting today, this specific combination with only 19 patients is clearly not a standard of care. However, we already had the situation that we had patients with MSI high tumors which were no good candidates for surgery. And the question was on the table, is immunotherapy an approach for them? And I would say with these high rates of complete responses, if patients really have contraindications against surgery, I would go for this treatment. But however, whether this will be becoming standard of care, larger trials will have to show us.
Thank you, Dirk, for this very interesting 3 studies that you presented. And I think, although, as you have mentioned, not relevant so much at this very moment, but also I think they're showing us the way forward. And I wanted to ask you now from the patient perspective, a patient is diagnosed at this stage with locally advanced colon cancer. So what would be the recommendation? What do they do? Do they do some biomarkers or not?
Well, yeah, we ask for these biomarkers in the in the different guidelines, including the ESMO guidelines, we do say that in stage 2 or 3 disease, all of these three, it's not so many, but these three biomarkers, MSI status, RAS, and BRAF, should be present. And the consequences today, if patients have MSI high tumor, highly being sensitive to immunotherapy, I would in any case consider a preoperative treatment with an immunotherapy. And there are also so many trials open for the BRAF and the RAS mutations that it may be even relevant to consider a trial participation for the neoadjuvant treatment. If they don't have access to trials, well, for MSS patients, I would say this neoadjuvant treatment is not yet a standard of care. The Foxtrot trial is so much discussed in all of these different tumor boards. However, it's clearly not yet a standard of care, but I'm pretty sure that we will get more data and we will identify this patient group, which really should undergo preoperative treatment, whereas the remaining patients may get upfront surgery and then later have adjuvant treatment if they are nodal positive or if they are ctDNA positive. We will see this landscape will be changing very rapidly.
Very rapidly, and also I think there is a lot of promising data. You have mentioned 2 points that I would like to highlight, one of them being the clinical trials. So we very often hear from patients that they are not being offered clinical trials, although they would like this option to be discussed. Looking at the data presented from the NICHE-3 trial and last year from the NICHE-2 trial, I think this is really impressive. And, you know, I would always see a patient wanting to go that pathway also for other trials. So how would you encourage patients to seek for clinical trials?
Well, you if you're just saying this, you're already encouraging. I can only underline and support this. I think we have to work on both sides. We have to educate and to encourage patients to ask for clinical trials, and we have to put some mild pressure on investigators or physicians to offer clinical trials and for centers to participate into clinical trials. We do know clinical trials, that's a lot of work, that's cumbersome, that's underpaid in many situations, it's extra work, etc. But however, if we do see these benefits which arise from clinical trials here, I can only say we should both sides strongly encourage the participation.
Thank you. And the last point that I wanted to ask you, you know, looking at this approach when there is a type of treatment, in this case, immunotherapy or chemotherapy given upfront before the surgery, I think it highlights the importance of the patients being treated by the multidisciplinary team. Because the usual approach, if a patient goes to smaller centers, they might be operated and then receive the adjuvant treatment afterwards. And in this case, it is very important that the patient sees the whole multidisciplinary team. So there might be something given to them before the surgery. So what's your view on that?
Yeah, I agree. And that's super complicated since also the teams would clearly like to solve the problem by operation quite soon. And also, if you look to rectal cancer specifically, but also to locally advanced colon cancer, it's also difficult for a patient to understand why a tumor, which can be surgically removed, should be staying inside the bowel for another 3 to 4 months in rectal cancer before then it's surgically removed. So it's really difficult, and we have to, let's say, explain to make patients understand. And also at some sites we do have to explain and to teach the physicians to make them understand that this is the better way to go, that the patient is not disappearing, that surgery is still a part and the essential part of a cure for patients. But at some point, clearly, like in other diseases, it's better to have the neoadjuvant treatment than the adjuvant treatment. We don't ask this in breast cancer. We don't ask this in gastric cancer. There it has become a standard of care. And I think on colon cancer, we are now moving to this also.
I think it's great that we are moving into direction because it gives greater chances for survival and hopefully smaller recurrence rates, which is what we are aiming for. Thank you, Dirk, for this interesting discussion, and I hope to see you all next year.
Thank you.